So good morning, good afternoon, good evening, depending on where you are. It makes me really happy to see some familiar names that were here for the first session. Means I didn't scare you away too badly. My goal for this is just to have a very simple, very big picture, broad introduction to the pathology of the different organ systems. So going to be covering everything from skin to nervous to bone to eyes to ears, a little bit of everything. A lot of what I'm going to try to cover is just the very basics. What type, how's the tissue arranged, what cell types are there, a lot of very normal things. I think to be able to understand pathogenesis and the way that different agents affect different tissues, you really need to understand what normal is and then what those responses to injury in the different tissues are. So hopefully that's some of what I'm going to cover. A lot of this will probably be geared for, vet students if you're online, residents. These are very similar to some lectures that we gave to our residents when I was on staff at the Joint Pathology Center. So hopefully it's something you'll find useful. If you leave here with just one or two nuggets of information that maybe you didn't have before, I'm going to consider that a success. So without any further ado, I will go ahead and get started. Full disclaimer, I do try to keep this a little interactive, so there are just a couple of questions potpourried throughout here that I will hopefully be able to have you log into Poll Everywhere and answer. There will be a little QR code once we get to those where you can log in on the screen or on your computer and hopefully answer those. I am happy to answer any questions. If you have them, feel free to put them in the chat, and then Kaylin can interrupt me and I can just answer them as we go. I tried to start each system with just a little bit of an agenda of what we're going to be covering. Like I mentioned, it's going to be a lot of normal things. So what is the normal anatomy of the urinary system? What are the parts that make it up? How is its blood supply organized? Components of the lower urinary tract are going to be included. So urethra, ureter, and bladder. And then I am also very interested in comparative pathology in different animals and the way things are different between species. So I always include a couple of slides at the end just to touch on some unique little comparative pathology nuggets that you might find useful if you're looking at multiple different species of animals. I do also want to disclose that the majority of the images and diagrams that I'm using throughout here are not mine. I did get them from a variety of references, a couple of the big ones being the main textbooks, so JKP, PBVD, as well as just BACA and BACA. If you've never used that, it's a wonderful, just normal veterinary histology atlas. Has a lot of pictures, a lot of explanations, very helpful. And then there's also some other lectures, intro lectures to the different systems that you can find online. So I've listed some of those here, but just keep in mind that a lot of these pictures came from some of those other resources. So what I would like to do is, and I'm noticing that my joining information isn't showing up on the screen that you have. So that's unfortunate. So we're gonna do this. Bear with me momentarily. Okay. What I'm going to have you do is, if you are on your computer, you can just go to this website, pollev.com/KelseyFiddes180, and log in, or you can do it by text message. I might have clipped this a little too close, so you might not be able to scan by the QR code, but you can also try that. All of these questions are going to have that same login information, so if you just stayed logged in there, otherwise I can go back and let you see it again. Sorry, I cut that off. First thing I would like to discuss is just what are some of the functions of the kidney, and in the event that we cannot get Poll Everywhere to work, feel free to put your answers just in the public chat and we will discuss based off there. So that'll be our backup plan for now. Downside of public chat is I know your names and I can call people out by name, but don't worry, I'm not mean. I wouldn't do that. The other thing I do want to emphasize here is this is just like a fun learning. It's not meant to name or shame anybody. So like there are no wrong answers. I mean, we want you to answer honestly and what you first think, and then we can discuss everything from there, why certain things are better answers than others. All right, can somebody tell me just in the chat if you are able to get logged into Poll Everywhere?
Yes, working good.
Okay, great. I am seeing a couple answers come in. Am I able to make it so you can see the answers? Let's find out, shall we? All right, some of the answers I'm seeing that maybe you are not is blood, filtration, filter. I'm starting to notice a common theme with some of those. Somebody said endocrine, great. Looks like these are all showing up on my screen, but not yours. So you'll just have to trust me that those are the things that you're saying. More votes for filtration, filtration. Yeah, I love it. Okay, yeah, so lots of answers for filtration. Some words in here about balance, electrolyte, balance, so maybe acid-base balance, probably a good one. Lots more filtrations, perfect. Okay, all right. Excellent, excellent. I love it. Okay, so the reason I wanted to touch on functions of the kidney before we even get started is you need to know what each organ does to be able to understand how it's structured and how it's made up. So here I did for this lecture, I tried to have a lot more pictures, but you can't put pictures for functions of the kidney. So this is going to be my like one wordy slide that you're just going to have to read. These are some of the main functions of the kidney that I want you to be aware of. When everybody said filter, what you mean is the elimination of waste. So one of the kidney's biggest jobs is just to filter things out. It has that fenestrated epithelium and the fenestrated endothelium in the glomerulus, and it uses that to get rid of all the waste products. There's a lot of resorption, secretion and resorption that happens throughout the length of the nephron. So acid-base balance, secretion and resorption of bicarb and hydrogen ions, maintaining salt and water balance. This is probably a big one that can cause a lot of systemic effects when it's out of its normal regulatory standards. There are a couple of pathways that you should probably be familiar with. So ADH or vasopressin that's secreted from the pituitary is very important for sodium water balance. And then the renin, angiotensin, aldosterone system is also very important. So we will touch on those as we go through the different parts of the kidney, just to show how those play into it. Definitely responsible for potassium ion resorption in the proximal tubules. And then there's a lot of endocrine functions as well. So the kidney does a lot of things that don't have to do with actually really the blood flow or eliminating waste. So that's kind of one to just keep in the back of your mind. It's very important for vitamin D metabolism. It creates the active 1,25 dihydroxycholecalciferol form of vitamin D that your body needs. That can have effects on the parathyroid. It can affect calcium phosphorus balance. Can have a lot of potentially very damaging effects when it's either produced too much or not enough. Erythropoietin stimulates red blood cell production. So if you're anemic or hypoxic, very important. And then regulating blood flow. So has some endocrine effects that have to do with the juxtaglomerular apparatus. So I've got a slide on that coming up, and we will discuss all things about that. So let's learn what some of these things look like, both grossly and histologically, shall we? All right, so we are going to start with just big picture, gross structure of the kidneys. So within the kidneys, one of the first things you need to be able to do is differentiate between lobes and lobules. So two different types of lobe arrangements in the kidney. They can either be unilobar or multilobar. So what that means is, like here in the cats and dogs, one lobe. Here in cattle and pigs, multiple lobes. Humans are the same way, NHPs are the same way, they're multilobar. When I say unilobar or multilobar, that also means unipyramidal or multipyramidal. So if you look at each of these lobes, it has this little triangle-shaped pyramid in it. These are the renal pyramids. It's that cone-shaped part of the medulla that is made up of all the collecting ducts, vasa recta, loops of Henle, and then the cortex above it. So triangle shape is the renal pyramid. If you have multiple renal pyramids, it's a multilobar kidney. So humans, NHPs, pigs, and cattle are the big ones. And then cattle are the only ones that actually have external lobulation. So you can actually tell from the outside, it's like a big old cluster of kidney grapes, if you will. Unlike the pig, where the outside is actually very smooth and homogeneous, it doesn't have that same lobe-like arrangement on the outside, just on the inside. In dogs, something to know is that it's actually because of fusion of the multiple different lobes forming this renal crest that drains into the renal pelvis. That fusion, it can vary between dogs. So there might be some dog kidneys that you look at that almost seem to have multiple lobes, but they are fused. They do drain into one urinary space, so still considered unilobar. Similarly in cats, but in cats it's just a single lobe. It's not necessarily the fused crest-like fusion that you would get in dogs. When there are these individual pyramidal multilobar kidneys, they don't drain directly into the renal pelvis. They drain into these little calyces. So they have minor calyces that coalesce into bigger calyces that empty into the renal pelvis. Cattle are a little different. They don't actually have a renal pelvis, so it goes straight from those major calyces into the ureter. So let's look at a couple actual images of some of those. So this is a gross image of a dog kidney. I can't remember exactly what was wrong with this kidney, but not normal. But it shows enough of what I need you to see that we'll use it as an example. So you can make out this layer here of blood vessels. This is always a good landmark on gross examination of kidneys to look for. These are the arcuate arteries. We'll get into the vascular supply later, but it separates the cortex and the medulla. So everything out here, cortex, everything in here, medulla. And within the medulla, you might notice there's kind of an inner lighter area and an outer darker area. So they talk about like inner stripes and outer stripes. So there is a little bit of a division to the medulla as well. You can almost make out some kind of pyramidal type arrangement to this, but they are all fused. And then at that fusion is where it drains into the renal pelvis. So dogs, unilobar, one lobe draining into one renal pelvis. By comparison, look at a cow kidney. I think this was like a hemoglobinuric nephrosis or something like that. So also color-wise, not normal, but it has the normal anatomic structure. So external lobulations, you can see from the outside that it has multiple of those renal pyramids in there. So multilobar. And then each of those pyramids drains into this little minor calyx here, and then it drains into a bigger major calyx, and then from there it goes into the ureter. If this were a pig, it would drain into a renal pelvis and then go to the ureter. If you like pictographic images, I included those as well. I think those came out of PBVD, if I recall. So has some really great images that are labeled, so depending on how you like to learn. So now we know kind of the big picture gross arrangement. So they can either be unilobar or multilobar, and then further dividing from that, you can have lobules within the kidney. So when we go to look at the kidney histologically, when we go to look at any organ, you should have a specific checklist of tissues that you need to look at, evaluate. You need to know what normal is and what abnormal is. And you need to make sure that you go through every single one of these tissues every time you look at it. So this is just an example of what my tissue checklist is for the kidney, mostly to make sure I don't forget anything, because without fail, I guarantee you I will forget to look at the capsule and I'll forget to look at the vasculature if I don't go through this list every single time. For the kidney, some people like to evaluate the kidney based on the direction of blood flow. I prefer to just go outside in. So I usually start at the capsule, go to some of the renal corpuscles or the glomeruli, then to the tubules, then to the interstitial spaces, down to the renal pelvis, and then kind of go back through and look at all the vasculature. However you want to get through it, feel free, but just make sure that you have a standard orderly method to make sure that you check all of your tissues. So we are now one by one going to go through each of these tissues and kind of look at what normal is, and then look at some of the responses to injury that might indicate an abnormality in that particular part of the tissue. Okay, if you are still logged into Poll Everywhere, got another question for you. I suppose I can put back up the little login thing if you would like. My question for you is this. I have included two images here. So the first thing on my tissue checklist was the capsule. So these are both images from the capsule. What I would like you to tell me is which of these two images is from a sheep. So there's a specific feature of the capsule that is present in some species and not others. And that would tell you which one of these is likely from a sheep or other ruminant, as opposed to, say, a dog or a cat. And thus far, since you guys can't see the answers, I'm seeing, maybe I shouldn't tell you because then you're just gonna start putting it. I'm seeing a lot of people say mostly, we got like 71% saying bottom image, 29 saying top image, so a little bit of a split. Now some people are changing their mind and saying bottom image. Yeah, okay, yep. Looks like a good number of answers, but the majority seem to be saying bottom image. So now I'm going to ask you to really go out on a limb. Is anybody willing to put in the chat why you think the bottom image is from the sheep? Ah, bless you, Kaylin. She's feeling brave. Thick capsule. So it does have a thicker capsule, but there's a specific thing about the capsule, part of which is making it thicker, that's important. All right, I won't torture you. I won't make you guys guess. So the important thing to note here is that, let me see if I can go to my next slide real quick. I can actually see things. Ooh. Okay, capsule. So the capsule here, so the top image is from a cat, bottom image is from a sheep, but it could be from some other ruminant. So it does have a thicker capsule, but it has this specific layer right here. So this is a layer of smooth muscle that's, I don't want to say unique, but it's something that's found in ruminants and not necessarily found in species like dogs and cats. There is another feature in this one that might tell you this is a cat. I won't ask anybody to out themselves and tell me, but here in the renal tubules, there's a lot of lipid. Lipid is very characteristic in the kidneys of cats, just as a normal finding. So some of those little species-specific differences might point you towards being able to tell what species it is. So I can't remember if I touched on this when I talked about the integument system, but there's little differences that whenever you get a tissue, if you know what animal it's from, just double check that the things you're seeing make sense for that type of animal. So if somebody tells me that this is a kidney from a cow and I'm looking at it and I see a single fused renal crest, that should trigger something in my brain and go, wait, this isn't the normal anatomy for a cow. So either there's some type of anatomic abnormality, or maybe somebody at the lab mixed something up. Maybe they sent me the wrong animal's tissues. Maybe they just said by mistake that it was a cow and it was actually a dog. So keep that in mind, things that'll point you towards what animal you're from. If I mentioned it in the skin, sometimes you can look at like the sebaceous glands around hair follicles, and cats, for example, have very uniform, nice, similar size, well-arranged sebaceous sebocytes within their sebaceous glands, as opposed to dogs where there's much more variability in the size of the sebaceous glands. So in here, capsule of the kidney, if there's this layer of smooth muscle, think that it's probably from a ruminant. Cats, if you see a lot of lipid, there can be renal lipidosis as a pathogenic thing, but in the kidneys of normal cats, you're going to expect a lot of lipid within the epithelium of those tubules. All right, moving on from the capsule. So my next two tissues after the capsule were going to be the glomerulus as well as the tubules. So those two things together make up the nephron. So the glomerulus surrounding it has Bowman space. Bowman space has a lining on either side of it. So there's a lining over the glomerular tuft, and then there's a lining on the outside. Between those is your urinary space or Bowman space. These two things together, the glomerulus and then Bowman space, make up the renal corpuscle. So if I say renal corpuscle, I'm talking about the glomerulus and Bowman space all together. The tubules, there are a lot of different tubules, different segments to the tubules. We're going to talk about some of the histologic features that'll help you to differentiate which part of the tubule you are seeing histologically. But there are a lot of metabolic things that I will only briefly skim over. The different parts of the tubule secrete and absorb different things. So some of that's important. I'm going to make you dive into that a little more on your own to get into the specifics of that, but we'll just touch on some of the big picture things. The other thing I do just want to highlight here is this image shows pretty nicely what a renal pyramid would be. So remember I mentioned that renal pyramid is that inverted triangle shape within the medulla. So that's going to be composed of these collecting ducts and loop of Henle. So you have this separation right here, cortex on the top, medulla on the bottom. Those renal pyramids are going to be right here, and they're going to contain these loops of Henle, some of the vasa recta vessels that are around it. and then the collecting ducts. A renal lobule, so remember I said the lobes, you have the kidneys that are either unilobar or multilobar. Next step below that is a renal lobule. So a renal lobule is going to be a collection of nephrons and their collecting ducts. So think of many of these nephrons, so all of the tubules plus the renal corpuscle, all draining into these ducts, and then all of those nephrons together with the collecting duct make up the renal lobules. This becomes important when we start to think about the blood supply, because a lot of the blood supply is it's very well named in the kidney in that it is named after being lobar or lobular, and that kind of points you to where the different vessels are. So just keep that in the back of your mind as we go through here. So histologic image to help you out with understanding what the nephron is. So this image has mainly cortex. So this green arrow here has all of the cortex. Blue arrow here, this is going to be the medulla. So remember that medulla, that if you have a multilobar kidney, is going to have those pyramids. Within that part is going to be your collecting ducts and loop of Henle. So here's another pictographic image. Collecting ducts, loop of Henle, that's going to make up your medulla and your renal pyramids. And then your cortex, you're going to have your renal corpuscle, so your glomerulus and Bowman's space, as well as proximal and distal tubules all throughout here. You will notice that there's kind of a linear arrangement to some of these tubules within the cortex. That's referred to as the pars radiata or medullary rays. So these are made up of some of the parts of the loop of Henle and collecting tubules. So kind of these straighter parts that are within the cortex form the pars radiata, as opposed to the pars convoluta, which is kind of all these twisting, turning, a little more intimately associated with the glomerulus. That's going to be all of the proximal and distal convoluted tubules. So convoluted means they are literally convoluted. They're kind of curled and coiled on themselves. All right. Something to keep in mind here. They don't always have a histologic difference, but there are two different types of nephrons. So there's cortical nephrons, so cortex kind of on the outside, and then juxtamedullary nephrons. So these are going to be the nephrons right at the border of the medulla and the cortex. They look histologically similar in most species, but there is a difference in that the majority of the nephrons are cortical. So about 70% of them are cortical nephrons, about 30% are juxtamedullary, but the majority of the blood flow goes to the cortical nephrons. Why that's important to know is because it's the juxtamedullary nephrons that have the long loops of Henle. So look at these two images here. Cortical nephron, pretty short loop of Henle. Juxtamedullary nephron, long loop of Henle. So the long loops of Henle are very important because they play the largest role in urine concentration. So the concentrating ability of different species directly proportional to the length of that loop of Henle. So people always use the example of desert-dwelling rodents. They're going to have very long loops of Henle because they need to conserve water. If you think of animals that are very susceptible to dehydration, like baby pigs, it's because they have very short loops of Henle. So if they have short loops of Henle, they can't concentrate their urine, they can't conserve that water, and they're very susceptible to dehydration and subsequent injury from that. All right. So let's break this down. So we talked about the nephron, the renal corpuscle. Renal corpuscle made up of the glomerulus, so a bunch of different images here, all showing a central glomerulus. You have Bowman's space right here, and then you have this parietal layer overlying it. So this parietal layer is a simple squamous. You also have a visceral layer that overlies the tuft. This visceral layer has podocytes with foot processes. So if you remember what you were all saying for the functions of the kidney, filtration. The glomerulus is important because it has fenestrated endothelium. So it has spaces where things can fit through the endothelium, and then you have these foot processes of this visceral layer podocyte foot processes that kind of interdigitate with the basement membrane and also help to kind of regulate that filtration from that fenestrated endothelium. The actual glomerulus, it's basically a tuft of capillaries. So a lot of the cellularity you see here is going to be endothelial cells. Without TEM, it's very hard to differentiate between the endothelial cells and then those podocytes or that visceral layer of Bowman's capsule. So TEM, looking at the glomeruli, can be very helpful to tease those apart. There's also mesangial cells in here. So the mesangial cells produce extracellular matrix. They're important for the structural stability of the glomerulus. So some of those are mixed in here as well. There's not really any good morphologic differences to tease those apart, but if you did have TEM, you would be able to tell the difference between those. Okay, so like I mentioned before, on this lower right image here, I actually don't know if it's like an AI generated image or an actual TEM image, but this is what it would look like on TEM. You have this visceral epithelial cell, so that's going to be your visceral layer of Bowman's capsule, so that inner layer of the urinary space. The foot processes kind of come down here and interdigitate on this basement membrane. And then you have the endothelium here, which is fenestrated. So it has these little slits. Things can diffuse through here, get through the basement membrane, go through these foot processes, and then enter the urinary space. So that's how ultimately the ultrafiltrate of the urine is produced. The fenestrated endothelium doesn't let everything through, though. It's relatively impermeable to larger molecules. So if you think of albumin or hemoglobin, usually those things can't get through. If those things are getting through, there's probably something wrong with the glomerulus. Things like sodium, potassium, those can pass through there relatively freely. This exchange of molecules passing through here is what's necessary to eliminate waste. So filtering the blood, getting rid of that waste through this fenestrated endothelium. The glomerulus, it's those convoluted capillaries. So all of these capillaries, a couple higher images that show the capillary loops here, capillary loop, fenestrated endothelium, basement membrane, visceral epithelial cell, urinary space, parietal epithelial cell. So most of those can be made out histologically. Got a nice capillary loop here. Would be hard to tell if this was a visceral epithelial cell or an endothelial cell, but it's one of those. Then you have the urinary space, and then you have this parietal epithelial cell layer over the top of it. The mesangial cells that are kind of intermixed in here, so this shows a nice little image of a mesangial cell. They're modified pericytes. So pericytes are the microvascular cells within the wall of blood vessels. They're contractile, they can be phagocytic, but their main job is to produce collagen and matrix, or if there's damage, they can also secrete inflammatory mediators. Okay, so let's talk about things that might make it easier to identify abnormalities. Histochemical stains when it comes to the kidney may or may not be helpful. As I mentioned before, TEM is probably going to be most helpful, but in the absence of TEM, you might be able to use some of these histochemical stains to tease out abnormalities either in mesangial cells or basement membrane or the podocytes of that visceral epithelium. The stains, the basis of the stains is that they're going to stain the basement membrane. So when you think of silver stains and PAS, they're very good at staining basement membranes. This is helpful in the glomerulus because there's a lot of pretty well organized normal basement membrane within those capillary loops. So if you think back one image, all of this basement membrane is going to be very well highlighted, basement membrane here. It's going to be very well highlighted by both silver stains, so JMS, as well as PAS. And then from that, you might be able to identify abnormalities. So are there holes? Is there like a double train track appearance to it that would indicate like splitting of the basement membrane or something within the basement membrane? You might look for little spikes, little holes. Mason's trichrome, this is also a good one. It helps to identify collagen. So collagen is always going to be blue. So if there's fibrosis of the glomerulus or periglomerular fibrosis, it'll help highlight that. It also can stain immune complexes. So I'm going to touch on immune complexes a few times, but the glomerulus is a very important location where immune complexes are filtered out, and they can also get deposited in the glomerulus and result in glomerulonephritis. So Mason's can stain some of those immune complexes red, can also be helpful for amyloid. It stains it like a bluish orange color. So some utility to that. These are all normal glomeruli and how they would stain with those different stains. But I did add one image here that just shows you some of the utility of a silver stain. So if I go back real quick, if you look at this silver stain, it's all pretty homogeneous, pretty thin, uniform. Silver stains can be a little messy, so these can be a little hard to read. But when you compare it to this, you kind of almost have like this like fibrillar brush-like appearance to the outside. This is what they call like spikes and holes. So it identifies that there's some type of abnormality to that basement membrane. So I think this one was from one of the immune complex glomerulonephritis. So in the absence of TEM, histochemical stains can help you a little bit. All right, so changing it up a little from my integument lecture, I did try to include a little bit more of response to injury and damage of the different parts of the tissue. So within the glomerulus, response to damage, there's a few different pathogeneses for how the glomeruli are damaged. In terms of the entire kidney as a whole, the most important thing to keep in mind is this intact nephron hypothesis, which basically just means if you damage any part of the nephron, so any part of the tubule, proximal convoluted tubule collecting duct, any of the vessels around it, it can damage secondarily the glomerulus. Similarly, if you damage any part of the glomerulus, the capillary tuft, the basement membrane, you're going to get some downstream effects on the tubular blood flow and damage to the tubules as well. So it's all interrelated. If you damage one part, it's probably going to cause damage to the other part. Glomeruli can also be damaged if there's increased pressure. That just damages these fragile capillaries. In some species, high protein diets can cause hyperfiltration. And then once again, back to this immune complex deposition. So glomeruli, primary site for removal of these, and then they can be deposited in different locations. So either below the endothelium, below the visceral epithelium of Bowman's space, or within the mesangium. And you really do need TEM to tell exactly where it's being deposited. When you get this deposition, it stimulates inflammation, release of cytokines, damages basement membrane. When you have damage to the basement membrane, all kinds of things can get through the capillary that shouldn't, or things that should get through there can't. And then it can cause pressure on less affected nephrons, further damage. Then if you're damaging the glomeruli, intact nephron hypothesis, you're also going to be damaging the tubules. When you have damage to the glomeruli, you do have to think about how you're going to describe it, how you're going to characterize it. So I included a couple images here that just show different degrees of glomerulosclerosis. So these I think are PAS stains, but this is pretty much an entirely sclerotic glomerulus. So I would call this global. It's affecting the entire thing, global glomerulosclerosis. And then you can also have segmental. So it can either be segmental or global, depending on if it's affecting part or all of the glomerulus. And then also you have to decide how many of the glomeruli within the kidney is it affecting. So generally for the kidney, if less than 50% of the total glomeruli in the kidney are affected, it's considered focal. It's considered diffuse if greater than 50% of the glomeruli are affected. A few other representative images just to show some other responses to injury. So periglomerular fibrosis, some more of that glomerulosclerosis. There's thickening here, not necessarily fibrosis, but just thickening the basement membrane of Bowman's capsule. A lot of cellular hypercellularity within Bowman's space here. Cystic atrophy, so think if there was like stones or downstream obstruction and you can't urinate or get that urine out, you can get some of this cystic atrophy just because of the upstream effects and inability to void that urine. Within Bowman's space, you can get a variety of different cell types. You can get fibrin, you can get hemorrhage. All of these things can form crescents within there. You can get lipid deposition, lipid emboli, lipid within foam cells. Synechia, if you have adherence, I don't think there's a good image here, but adherence of the glomerular tuft to Bowman's capsule. So those are all just different types of injury that can occur to a glomerulus. All right, moving on to some of the meat of this, we're going to talk about the tubules. So tubule arrangement and organization. So we've already talked about the glomerulus. So you have blood, it comes into this capillary tuft of the glomerulus, things are filtered out, and there's this ultrafiltrate that's formed within Bowman's space. From Bowman's space, it's going to drain into the proximal convoluted tubule. From there, there's a teeny tiny little straight proximal part, and then it goes into that loop of Henle. Remember, long loops of Henle for animals that really need to concentrate their urine. From there, it goes to the distal convoluted tubule, to the collecting duct, and then to the papillary duct, out to either one of the calyces if it's a multilobar kidney, or to that renal pelvis if it's something like a dog. All right, this one's not going to show up very well, but I want you to take just like 2 seconds and look at this image. So within this image, if I had this working where you could see the answers, you would be able to put a little pin on this map and tell me where you think the distal convoluted tubules are. So I will tell you in this image, there's a couple of glomeruli, so glomerulus here, glomerulus here. There are collecting ducts, there are proximal convoluted tubules, and there are distal convoluted tubules, as well as some vessels. So take like 2 seconds, look at this image, and if I asked you to put a pin on a map and tell me where the distal convoluted tubules are, could you do that? And I have no doubt that most of you probably could. And while you can't see the answers, I can see what people are putting for answers. And I would say maybe about half of the people are getting it. So I've gotten a couple answers here, answers here, answers here, and then a couple answers in here, a couple answers over here. All right, great. Let me double check that I have this image on the next slide. Not sure if I do, so I'll just show it while I'm still on here. So within this image, if you were one of the people that said anything kind of in this area, hopefully you can see my little laser pointer, maybe these guys right here, these guys right here, any of those can be considered the distal convoluted tubules. There are histologic features that would tell you that those are the distal convoluted tubules. Just like if I asked you to say proximal convoluted tubules, any of these in here, you would be able to identify as proximal convoluted tubules. If I asked you to identify collecting ducts, you would be able to tell me that these are collecting ducts. So let's go ahead and touch on what some of those histologic features are that are going to help you tell those apart. So starting with the proximal convoluted tubule, in my brain, I feel like these are the easiest to identify, but also the most frustrating to look at, just because so many of the kidneys that we see usually come from necropsies, and they're often autolytic. And when you get autolysis in the kidney, it can be really hard to tell what's an actual pathologic change and what's just autolysis. So that can make this a little confusing. But the proximal convoluted tubules are nice because they have this very distinct brush border that are going to tell you they're proximal convoluted tubules. None of the other tubules in the kidney have this brush border. So if you see this brush border, you could stain it with a PAS. It'll stain beautifully like in this image. Microvilli on that apical surface. The proximal convoluted tubules need this brush border because it increases the surface area for absorption. So the proximal convoluted tubules are very important for absorbing up to 80% of that ultrafiltrate is going to be resorbed here in the proximal convoluted tubules. So it's resorbing sodium, chloride, and then when you have sodium and chloride, water is going to follow. So it also helps to resorb water. There is a lot of hydrogen ion secretion that occurs here, and then also some absorption of other things like potassium, albumin, glucose, bicarb. So anybody that said that acid-base balance, proximal convoluted tubules, going to be important for acid-base balance because of some of that hydrogen bicarb exchange that's happening. One thing to keep in mind, the proximal convoluted tubules, they're very susceptible to toxic injury. Part of that is because they're the first place that the urine goes. So if you have a toxin in the urine, it's going to hit the proximal convoluted tubules first. So susceptible because of that. It's also susceptible because they have a very high metabolic rate. So because they're doing so much active secretion and resorption, high metabolic rate, lots of mitochondria, and because of that high metabolic rate, very susceptible to toxins, very susceptible to ischemia. When you get ischemia or hypoxia of the tubules, you lose that actin cytoskeleton, so you get breakdown of those villi. And once it loses its villi, it's losing its surface area and it can't secrete and absorb what it needs to. All right, the loops of Henle. As I mentioned, there's a couple different parts of the loops of Henle. So from proximal convoluted tubules, there's this thin descending limb. It kind of circles back on itself, all of this happening in the medulla, to this ascending limb, and then it becomes a thicker ascending limb. So you can have thin parts, you can have thick parts. Important thing to keep in mind, they're not going to have that brush border. So no brush border. Depending on if you have a thick loop or a thin loop, that can change what the nuclei and what the cells lining it look like. So generally, the thin segments of the loop of Henle, they have this simple squamous epithelium, and then it gradually changes as it gets to this thicker part to be more of a low cuboidal. Once again, no brush border. Proximal convoluted tubules, those are the ones with the brush border. The primary segment responsible for the concentration of urine, that's going to be this loop of Henle. So long loops of Henle, resorption of water, species that need to conserve water. The different parts of the loop, so that thin versus thick loops, do absorb different things. So this thin descending loop primarily resorbs water. Then the ascending limb actively absorbs solutes, so sodium and chloride. So if you have that ascending limb absorbing sodium and chloride, that's going to pull even more water out of the descending loop. So they kind of work together, that descending and ascending limb, because they're right next to each other. So you have one that's pulling out water, you have a bunch of vessels around there that are taking that water away, and then you have that other ascending limb that's pulling out sodium, and because it's pulling out sodium, you're going to have water following it even more out of that descending loop. So those two things work together. That symbiotic relationship between those loops is often referred to as a countercurrent multiplier. So basically it's just working in conjunction to absorb and resorb as much water as it can through absorption of solutes and then that permeability of water of the descending loops. Okay, almost last but not least, the distal convoluted tubules. These can look very similar to the proximal convoluted tubules, but they're usually a little more basophilic. The lumen appears to be a bit bigger because it's not filled with all that brush border microvilli. They might seem a little more basophilic. That's probably how a bunch of people picked it out of the first image. So no brush border, maybe a little more basophilic. The nucleus is located closer to the apex as opposed to the proximal. It's more central or basilar. And then, like I mentioned, the less acidophilic cytoplasm, so a little more basophilic in appearance. Distal convoluted tubules, their function, once again, water resorption, regulated mostly by antidiuretic hormone or vasopressin and aldosterone, as well as resorption of glucose and amino acids. Okay, so before completely leaving the distal convoluted tubules, there is a part of the distal convoluted tubule that comes into contact with the arterioles that are going into that renal corpuscle. So we have our nice little glomerular capillary tuft, we have this artery coming into it, and then we have these distal convoluted tubules around it. When the distal convoluted tubules come into contact with that, there's a specialized structure there known as the macula densa. So the macula densa is very important for regulating blood flow. So regulation of blood flow and then tubuloglomerular feedback to either increase or decrease the amount of blood flow. So afferent arteriole, within this arteriole, there are some kind of epithelioid looking cells here within the wall of it. These are modified smooth muscle cells or juxtaglomerular cells. Sorry, I don't want to cough into my microphone. Also part of this juxtaglomerular apparatus is going to be the efferent arteriole, so the arteriole that's leaving the kidney. So we're primarily worried about the afferent arteriole, what's bringing blood into the glomerular tuft. This macula densa over here that's within the distal convoluted tubule, it senses sodium and chloride concentration. So if you have low sodium, it's going to stimulate these juxtaglomerular cells to secrete renin. Renin probably sounds familiar because it has to do with that renin, angiotensin, aldosterone feedback. So when renin is secreted by these epithelioid juxtaglomerular cells, you get vasoconstriction. So it raises the blood pressure and then changes the flow and the amount of ultrafiltrate that's produced. Does some other things. It does increase sodium resorption. So if you increase sodium resorption, you're also going to get more water. Water tends to follow sodium because of the osmotic gradient. Stimulates ADH secretion from the pituitary. That increases the permeability of the collecting ducts, so you get more water resorption. So all of these things to say, this macula densa here in the distal convoluted tubule senses sodium, and if sodium's low, that means that probably hypovolemic or low water as well, and it's going to try to do all these things to increase sodium resorption and increase water resorption from the kidneys. That's the importance of the juxtaglomerular apparatus in very simplified terms. Okay, and then after all of this, very last part goes into the collecting ducts. I like the collecting ducts because not only are they part of that pars radiata, so they're very linear, non-convoluted, that helps you pick them out histologically, but it also has some other histologic features. So if you look at these guys, these have pretty well demarcated cellular borders. If you think back, I'll go back real quick to the distal convoluted tubules, or even to the proximal convoluted tubules, all these cells kind of blend together. You can't really draw the line in between the cells of where they are. And here in the collecting ducts, you can make out each and every one of these individual cells. So it still has a simple cuboidal epithelium, similar to the distal convoluted tubules, but there's a very clear demarcation between neighboring cells. They tend to become more columnar in appearance as they get to the papilla, and that's where they form the papillary ducts. Papillary ducts, I think they're also called the ducts of Bellini, but these parts of the medullary rays that extend to the tip of the medullary pyramids, so pyramids within the medulla, that's all part of these collecting ducts. Permeability of the collecting ducts, so I've mentioned antidiuretic hormone or vasopressin a couple times. When you're trying to increase your water retention or stimulate water resorption, you want to increase your antidiuretic hormone. That affects the permeability of these collecting ducts to water. So increased permeability, they're able to absorb more water. Okay, when the tubules are damaged, how can the tubules be damaged? Lots of different things. Any type of hematogenous infection, so things that are spread through the bloodstream, can potentially affect the tubules. Ascending infections and direct damage of toxins. So if there's toxins within the urine that gets into the tubule, you're going to get that damage kind of from the inside out. Similarly with ascending infections coming up from like a UTI or a bladder infection, gets into that renal pelvis, and then it can spread up these tubules, cause intratubular inflammation and damage. The kidneys are very sensitive to hypoxia from ischemia and infarction because of their blood supply, which is one of the next things I'm going to get to. And then secondary things, anything that damages one part of the nephron or one part of the kidney is probably going to have some secondary effects on other parts of the kidney. So if there's fibrosis, obstruction, compression along any part of the nephron, any part of the kidney, probably going to get some tubule damage. All the things that can happen: degeneration, necrosis, hypertrophy, atrophy, ectasia, things accumulating within the lumen, so casts, resorption of extra protein can cause some hyaline droplets. You can get pigmentation within the renal tubular epithelial cells. Some of those pigments can be hemosiderin, lipofuscin, bilirubin, depending on what's going on. One thing I do like to keep in mind is that the tubules can regenerate, but that's only if the basement membrane's intact. So if you have ischemic damage, you usually lose the basement membrane and they can't regenerate. But a lot of nephrotoxins, those just affect the epithelial cells. They don't affect the basement membrane, it stays intact, and they regenerate. Few images here just to show some of the differences, and this is probably the frustrating part, is trying to look at tubules and decide, is this autolysis or is this actually a pathogenic problem that I'm seeing? So the classic histologic appearance of ischemic injury is going to be coagulative necrosis. So up here, these renal tubules, they've lost pretty much all of their differential staining, but you can still make out the tubular architecture. So that's probably some type of hypoxic injury. You also have some corroborating evidence that this is a real change in that there's some inflammation, some intratubular accumulations of things in the tissue adjacent to it. Lytic necrosis, on the other hand, so like endotoxins can do this, bacterial infections, things like that. Lots of cellular and karyorectic debris. I will add the disclaimer that if you were to look at a tubule like this, autolysis can look exactly like this. You can get loss or sloughing of those epithelial cells into the lumen. What you really want to look for is you want to look for the cells that are kind of stretching out and trying to cover that damaged basement membrane. So some of these cells have lost their cuboidal architecture and they're kind of stretching out and trying to cover some of the more damaged area. So that's one thing that you can look for to help you identify that maybe this is a real change versus autolysis. This image down here, you might notice that the tubules are just they don't really have lumens. There's a lot of piling up of these cells. There's some mitotic figures, increased basophilia. This is all characteristic for regeneration. And then vacuolation of some of the tubules. So I think these are the proximal convoluted tubules, have some vacuolation in this image down here. Okay, a few other representative images that I am just gonna briefly talk about. Accumulation of things within the lumen. So you can get red blood cells, you can get proteins, you can get cellular casts, all of those accumulating within the tubular lumina. You can get resorption of proteins, excess resorption of proteins that can cause these little hyaline droplets within the epithelium. There are inclusions that can occur in the kidney. They can also occur in the liver, but they're just kind of these brick-like intranuclear pseudo-inclusions. So don't let that fool you and think it's like a viral thing. This here just shows some tubular atrophy and then sclerosis of the basement membrane around it. All right, we are going to move on to the renal interstitium, and I am going to give you an apology that I'm going to run over time. So if you have to leave, I totally understand. You can watch this on YouTube later, but these two images here both depict renal interstitium. My question for you would be, which one of these is normal? Top image, bottom image, both images, or neither image? And I already see some answers. I see answers for top image. I see answers for neither image. Okay, great. I see a couple answers chiming in for both images. All right. And I do want you to focus mostly on the interstitium of these images. Which interstitium is normal? Ooh, looks like we're getting more people changing the answers to both images. Okay. All right, so we got about a even split between both images and top image. So top image is correct. Top image is normal. Bottom image is also normal. So the interstitium can have a variable appearance depending on where you're looking at it. So this is just two different parts of the kidney. So up here is interstitium from the renal cortex. Down here is interstitium from the renal medulla. So you tend to have more interstitium and more matrix within the interstitium of the medulla. Also keep in mind that just an aging change, you can get extra cellular matrix that accumulates there just as an aging change also within the medulla. So can potentially be, quote, quote, not normal, but just an incidental thing that happens in older animals. All right, so the interstitium. More interstitium in the medulla than the cortex. Medulla down here, cortex up here. It's just this fine fibrovascular connective tissue. There's a few fibroblasts, not a whole lot, a little bit of connective tissue, some extracellular matrix. Like I mentioned, those glycosaminoglycans can increase with age, can also increase with ischemic or hypoxic damage. So if you get expansion of that interstitial space, could be either one of those things. There's also the blood vessels, nerves, lymphatics, all of those things live within the interstitium. Cells in the interstitium, especially within the medulla, are also responsible for production of prostaglandins. So pathogenic thing-wise, when you think of cats that get NSAIDs, those can have an effect on prostaglandin production. Those prostaglandins affect blood flow. They also affect sodium and water excretion and resorption, and they can also affect renin secretion. So all of those things we've talked about that affect water, sodium balance, come into play in the interstitium, especially in the medulla. All right, things that happen in the interstitium, kept it just very broad. Kind of the big three are going to be edema, fibrosis, and inflammation. The inflammation can extend from the interstitium into the tubules or vice versa. Interstitial nephritis, if you do a lot of lab animal stuff like I do, I would challenge you to find a mouse kidney that doesn't have a few interstitial lymphocytes somewhere in the kidney. So it can just be a non-specific background lesion in some animals. Tubulointerstitial nephritis can result from ascending infections, hematogenous infections. Few images here that just show some of the chronic tubulointerstitial nephritis. You'll notice this kind of nodular appearance to the capsule. This looks just very knobbly and nodular. That's pretty characteristic with fibrosis. You get contraction down, causing that nodular appearance. Inflammation here, both within the tubules and within the interstitium. This has a Masson's trichrome on it, so very good at highlighting that blue collagen or fibrosis within the interstitium. Up here, you're also able to see some glomerular changes, so some glomerulosclerosis, some global glomerulosclerosis, tubular accumulations of proteinaceous material. There's some atrophy of these tubules, inflammation. So lots of those changes of the different parts all go hand in hand. Damage one thing, you're probably going to get damage to the other. All right, last but not least, the thing that I always forget to look at, renal pelvis. Big time that this comes into play is when there are ascending infections. So ascending infections, you can get accumulations of inflammatory infiltrates within that renal pelvis, and then that can spread up through these papillary ducts up into the rest of the kidney. A couple images here that just show some of that inflammation within those tubules. If you have a UTI, that's probably the most common one. UTIs, they can just spread up the ureters and then up into the renal pelvis and kidney if they are long-standing. Okay, vasculature. Vasculature of the kidney, very important. So even though the kidney is a very volume-wise minor part of the body, it takes about 25% of the cardiac output of blood that it needs. If you interfere with that glomerular flow, that's going to affect the tubular blood flow. So those two things work hand in hand. If you don't get blood to the glomeruli, you're not going to get blood to the tubules. The medulla, very sensitive to ischemic injury or if there's some type of vascular occlusion. We mentioned those prostaglandins. So cats that get NSAIDs interrupt prostaglandin production. So you get decreased blood flow and ischemic damage because cats are so susceptible. That's why you would get that characteristic renal crest necrosis with excess NSAIDs in cats. Couple images up here that just show different types of vasculature. So upper left, this is just one of the arcuate arteries. This is just one of the intralobular arteries. The nice thing about the kidneys is that renal blood flow tends to maintain itself pretty stable, largely in part because of that juxtaglomerular apparatus. So even when you have a wide range of arterial systemic blood pressures, it tries to keep that glomerular filtration rate pretty stable with the blood flow. The blood flow is normally directed primarily towards those outer cortical nephrons. So remember the juxtamedullary nephrons, those are the ones that have the long loops of Henle and do a lot of the work for concentration of urine, but most of the blood flow goes to the outer cortical nephrons. Therefore, when you have reduction in renal perfusion, primarily affects the cortex. All right, vasculature. The vasculature is named very logically and makes a lot of sense to me, so I absolutely love it. Comes in and out through the renal arteries and veins. From the renal artery, presumably if you have a multi-pyramidal or multi-lobar kidney, first division from that renal artery is going to be into the interlobar arteries and veins. So goes between each of those lobes. So remember, those lobes are what separate all these little pyramids of the medulla. From the interlobar arteries, it courses up here to the corticomedullary junction, where you get branches off into the arcuate arteries. From the arcuate arteries, it goes to the interlobular arteries. So remember, our lobules are going to be a whole bunch of these nephrons, the glomeruli and the tubules draining into the collecting ducts. A bunch of those together make up the lobules. So interlobular artery. From there, afferent arterioles, those are what go into the glomerular tuft, glomerular capillary, and then it comes back out. When it comes out of the efferent arteriole, it forms this vasa recta. So when you get lack of blood into the glomerulus, you're also getting lack of blood to all of the tubules here. So this tubular network that comes from that efferent arteriole, that's why your glomerular blood flow affects the tubules. Comes out of there, intralobular vein, and then basically just reverses itself. Some species do also have a subcapsular venous network. Cats especially, the veins are in the capsule. So for like lymphomas or FIP, you can see the vessels on top of those cat kidneys really well. So when there's a vasculitis or something like that, it can be very noticeable on top of the kidneys. In dogs, they're more subcapsular, so a little more subtle in them. Responses to injury when you have damage to the blood vessels. Hyperemia, this can just be a passive thing. The animal died, blood stopped flowing, you get a passive congestion. There are some septicemias and toxemias that can cause active hyperemia. Hemorrhage, damage to the blood vessels, hemorrhage, lots of different causes of that. Turkey egg kidneys are something that are talked about in pigs a whole lot, but there's a lot of infectious causes that cause those subcapsular or renal cortical hemorrhages that give it that turkey egg kidney appearance. Thrombosis and infarction, lots of different causes of that. When you see gross images especially, if you look at the wedge shape that is formed, you can probably intuitively guess what arteries were affected. So if you remember what I said, it comes in through the renal artery, separates into the interlobar arteries, and then from there you have the arcuate arteries. So arcuate are at the corticomedullary junction. Because they're at that junction, if you have occlusion of the arcuate arteries, you're probably going to get a little bit of medullary and cortical infarction. So a little bit of medullary and cortical infarction, think arcuate arteries. The branch after that is the interlobular arteries. So these ones are more up here just in the cortex. So looking at some of these with the arrows, these ones here are only affecting the cortex. So those were probably thrombosis of interlobular arteries. The appearance can change. So this dark, deep red color, that's usually within the first couple days of an infarction. It becomes swollen, congested. Eventually, there's some leukocytes that infiltrate, kind of start to line around it, and then you lose all the hemoglobin within that, so it becomes more of a whitish color. Then after a couple weeks, you can get vessels that start to make their way in there and fibrosis. So these contracted down areas, these are just very chronic infarcts that have fibrosed down, and that's what's going to give you this kind of nodular appearance to the cortex, to the capsule of the kidney. All right, so let's touch on a couple of lower urinary tract and then comparative pathology things, and then I will let you be free a little bit late, and I'm sorry. Okay, so ureters. Ureters, they connect the kidney to the bladder. They are lined by a keratinizing, non-keratinizing stratified epithelium. It's always referred to as a transitional epithelium, and honestly, I think I went probably my entire residency and most of my pathology life always saying transitional epithelium and not really knowing what that meant. But kind of just like a broad definition of transitional epithelium is going to be, it's going to have multiple layers, and those layers are going to change shape depending on distension of that organ. So if the ureters are very distended, if the bladder is very distended, they might have more of a squamous morphology. Whereas if it's more flaccid, not distended, they might have more of a cuboidal or even columnar morphology. So that's just what's meant by the transitional epithelium specifically here in this case. Few different layers. There's the mucosal layer, so kind of forming these folds, if you will. The muscularis layer. There is an inner, outer, and middle layer to this muscularis, but within the ureter, they're kind of hard to tell apart. And then the serosa on the outside. So if we go from there to the bladder, these look remarkably similar. The layers are very similar, still has that mucosal layer. Mucosal layer can be a bit thicker, up to like 14, 15 cells thick, depending on the species. There's going to be a submucosa here. There's not a true submucosa in the ureters, but there is a submucosa here. There's also a tunica muscularis, but it can be very hard to identify. You might be able to see just like little tiny discontinuous muscle bundles here that are characteristic of the tunica muscularis. Submucosa muscularis, similar, it has inner, outer, and middle layers. These are also called the detrusor muscles. And then on the outside, the serosa or adventitia. Most of the pathogenic things that we think about in the bladder are probably going to be tumors, obstructions, and infections. So we've already touched on a little bit of that, so I'm not going to show many pictures or go any further into that. All right, let's touch on a couple of different species-related things, some of which I have already highlighted. Depending on the species, there are some differences in the histologic appearance of the glomeruli. So neonatal animals, very young animals, they can be much smaller and hyperchromatic. They can appear more cellular. So this is a fetal glomerulus from a neonatal piglet. Some of them in fetuses and neonates, near the cortex, the superficial nephrons, they almost have like this S-shape appearance to it. A couple of species, goat and sheep, they just have very cellular glomeruli. So I think this was a pig glomerulus. So very cellular, that's just normal for the species. If this was like a dog or a cat, you might think that there's a glomerulonephritis. And then horses, they just have the largest glomeruli in domestic animals. I think I included another image here. Yeah, okay, so this is just a comparison to a dog glomerulus. So notice the relative paucicellularity of this dog glomerulus when compared to goats and sheep, and that's just normal for those species. Birds, I'm going to be perfectly honest, birds are like one of my least favorite thing to look at, but I do just want to mention that they also have two types of nephrons. They have a cortical nephron and a medullary nephron. The cortical nephron in birds is referred to as a reptilian one because it doesn't have a loop of Henle. So birds, cortical nephrons, no loop of Henle, versus the medullary has a loop of Henle. So that's all I'm going to say about birds. Cats, gross thing to know is that cat kidneys normally appear much paler than other kidneys. So if you think of a dog kidney in that kind of bright reddish brown color, this more pale white, light tan color can be normal for cat kidneys. They can become even more pale with things like severe anemia, but just that pallor kind of golden yellow color is normal for cats. Why is that? Touched on it briefly, lots of lipid. So cats have lots of lipid, gives that kind of pale color, mostly in the proximal convoluted tubules. Horses, they're a species that within their ureter, they have very prominent mucus glands in the proximal ureter. So urine normally in most species is clear, clear to yellowish color. In horses, it's often cloudy because they get a lot of excretion of calcium, formation of crystals, and mucus produced by these glands in the proximal ureter. So that explains a little bit of a difference in the appearance of the urine in those species. Fish, first time I ever looked at a fish kidney, I was so confused because I had no idea what was going on and no idea what all these cells were. Fish kidneys, it's variable depending on the type of fish, but the anterior kidney in many fish will have some hematopoietic tissue. That's just what all these cells in here in between are, hematopoietic tissue. And then sometimes the posterior, actually sometimes the anterior kidney also can have endocrine tissue. So you can have endocrine tissue, hematopoietic tissue, totally normal within some fish kidneys. And last but not least, because I work with a lot of lab animals, I feel obligated to say it. There are these beautiful tox path non-neoplastic lesion atlases for rodents, mice, rats, primates. I think they even have dogs, pigs now. But there's a lot of just background lesions that don't necessarily have any clinical significance, but can just be background findings. Has beautiful pictures. So things like mineralization, some of those lymphocytic infiltrates, areas of fibrosis, lipid accumulation. If you haven't checked out those atlases and you do lab animal stuff, I would definitely take a quick look at those. All right, I apologize for going over time. I just couldn't help myself. I did put my email address here, so if you have any questions, feel free to email me anytime, or if there's any questions in the note or chat, I can answer them now or offline, depending on what Kaylin tells me. But I appreciate all of you tuning in to listen to me and letting me run over.
Excellent. No, that was great. That was great. I don't see any questions. We can give them a minute and hopefully we get one. But I thought that was really good. Thank you so much.
The nice thing about normals is there's not usually a whole lot of questions. It's once you start getting into all the pathogenic stuff that.
Yeah.